Okay, so now another crisis, which is COVID-19 in Nepal. So I will quickly highlight the health sector responses and the experience of health workforce in Nepal. COVID-19 is not the only crisis that Nepal faced. So looking at the past 2-3 decades, there were lots of crises that the country faced that affected the entire system and the health workforce. Be it the 10 years long civil war, the massive earthquake that we faced in 2015, the COVID-19 pandemic, and the recent floods that kind of affected the entire country, earthquake that a western part of the country faced, and the federalization, which also came as a shock to the health system in Nepal. So briefly, I'd like to inform you, how the decentralization has changed the structure of Nepal. So after 2015, Nepal adopted this massive decentralization reform where the country has now shifted to the federalization state where the powers, functions are devolved to 3 tiers of government, the federal, 7 provinces, and 753 municipal governments. So these 753 municipal governments are providing the basic health service delivery for their people. So it itself sounds very challenging that these 753 governments with different capacity are responsible and have the functions to provide the health services. So just to give in numbers, like health workforce, they are never enough for countries like ours. It's not only in Nepal, but it's the shortages is everywhere. So you can see in different cadres of health workers, the shortages are there. We do not meet the minimum requirements as set by the WHO. And 1/3 of the human resource for health that are produced in the country are working abroad. So here again, just to show you, none of the health category of the health workers are fully fulfilled in the country. But as you see that as you go to the higher level, the medical officers, the physicians, consultants, as you go higher, the numbers are decreasing. And compared to 2015, the recent health facility survey showed that the number that are fulfilled are even decreasing compared to previous years. So again, you can see that the red denotes the changes. So minus means the numbers are decreasing in all provinces. This shows that the severity of the shortages of the health workforce that the country is facing. So in this context, COVID-19 hit, and the health system, which was functioning with the shortages of health workers, where the health workers had a critical role to play. So COVID-19 hit, and in this context, we conducted this study where we used a cross-sectional exploratory study design. We interviewed 22 key informants from 2 municipalities in Lumbini province. We reviewed the policy documents that were released as part of the government response to COVID-19. We reviewed over 90 policy documents. Now my presentation will focus on the key findings from this study. So these are the major policies that we have in Nepal: the national health policy, health sector strategy, human resource for health strategy. These numbers of policy do talk about health workforce. They speak about strengthening the health workforce, mobilization, equitable distribution, and so on. So these are the COVID-19 policies that we reviewed over the 1-year period. So we reviewed over 90 COVID-19 policies which were directly or indirectly related to the health workforce. So now closely focusing on what we found from the interviews. On the COVID-19 policy formulation processes, we found that the policy formulation was largely done at the federal level because federal government is more responsible to handle the emergency situation in the federalized context. So the federal government was leading the policy formulation. Provincial government were only developing few policies, while the local governments were only implementing the policies. So despite they have this decision space to create their own policies or adapt the policies that were developed at the province or federal level, They were not doing it, they were not contextualizing the policies because they do not have the capacity to do it. And also the COVID-19 pandemic came as a pressure, as a challenge for them that in a way affected because they are dealing with the management of cases, and also they were just trying to implement the policies, which was in itself very challenging for them. And they were not contextualized. The health workforce voices were not heard during the policy formulation process. So this came as a challenges in the interview. On the intersectoral coordination, it was very good. It was very evident at the federal level, but the stakeholders, but the local governments were not kind of fully participating in these policy formulation processes, which they felt led to a less contextualization of the policies. After these policies were created, they were communicated to local government. Federal government used massive efforts to communicate these policies. They used numbers of channels, but largely through the public domain. So they used social media, websites, communications through telephone, radio, television. So all these sources were used as much as possible to communicate about the policies. However, what came up from the interviews were these were largely one-way communicated policies where the targeted health workers did not understand what that policy means. The policies were there. They were sometimes informed by the municipalities through phone that this is the updated policies, or this is the new policy, or this is the new protocol that you need to follow, but they did not know how to implement them. So the health workers who had the capacity, they relied on social media, websites, and then they did how they understood. But the health workers who had limited capacity, with limited access to internet, they were poorly informed on how to use these policies. So overall, the subnational governments, they were less aware about the policies, and the way they communicated the policies to health workforce was not effective, as it was said by the participants. Policy focus on the motivation and support to health workers, because the roles of health workers was very critical for the management of COVID-19. So there was policy regarding risk allowance, health insurance, rewards, appreciation. However, there were issues related with them because the incentives were not released timely. There was differences in allowance because as the municipal government, they hold that authority to have their own policies. So some municipalities are giving some amount of incentives and the other is giving a lesser amount. So that kind of demotivated the health workers. The leave and holidays was there, but as we know, because of these huge shortages of health workforce and the surging cases of COVID-19, health workers could not take leave, holidays, weekends, and they were kind of performing in rows for 3 weeks, 4 weeks without taking a day off. And physical safety and protection was an issue, but in the initial stage, but later the local government started to procure their own protective equipment. And on the experience in terms of mental health, there was a fear of COVID-19 among the health workers because they were providing service without having proper enough information on how to. They did not receive any orientation or any support from the local government, because the situation was so difficult and COVID-19 was evolving day after day. So there were changing protocols, changing algorithms. So all these created a kind of confusing environment for the health workers to perform. And they were kind of seeking some psychological support. They said that if they could speak to someone who can clarify how to do their job. So with these kind of feelings, they were performing their job during this situation. So stigma and discrimination, as it is a case in other countries as well, so health workers faced, and it was during the initial stage when COVID-19 was new to everyone. Health workers faced massive stigma in terms of using community services. Even they were restricted to enter in the community. They were threatened to leave jobs, leave home. But it was later resolved. So on the last slide, as key lessons, the policy formulation process for the management of this type of pandemic has to be very inclusive and participatory. In case of Nepal, it was participatory, but local government felt that they were less heard during the formulation process. And when it comes about the health workforce, when we are targeting any policies to health workforce, then we need to take their views, take their voices as well. That is one thing that came as a challenges in our study. In terms of communication, it has to be effective, more targeted to where the policy is intended to. So the health workforce were communicated, but not enough. They did not understand, and also there was no any mechanism to ensure that if they understood it well, so they did not receive any monitoring and supervision, and so the system, the local system, they did not know that if every health worker is having this common understanding of the guidance. And on the mobilization part, as in Nepal, we do not know the exact number of the health workforce that are operating within the country, because there are different entities, one entity that provide the education, one that recruit, and one that manage the health workforce. So in this environment, if we have a proper human resource mobilization plan at all tiers to use during the time of crisis, then that would be very effective. And the last one is, of course, training, motivation of health workforce is very critical. So we need to appreciate, we need to create a system where providing incentives and providing mental support will encourage them and not discourage them to provide this service. With this, I conclude my slide. Thank you very much.